Okay, hello everyone again. My name is Jonathan Sullivan, and I'm the Vice President of Product and Membership Design at the National Quality Forum. Welcome to this next edition in our special programming series on responding to the challenges around COVID-19. We appreciate everyone taking the time amidst this crisis to participate, and we hope it'll be informative for you as you face the many challenges with this pandemic. We are especially grateful to today's speaker, Dr. Lee Fleisher, for taking us inside the critical care preparations at one of Philadelphia's largest health systems. Dr. Fleisher is the Robert D. Dripps Professor and Chair of Anesthesiology and Critical Care and Professor of Medicine at the University of Pennsylvania School of Medicine. He received his undergraduate degree from the University of Pennsylvania and his medical degree from the State University of New York at Stony Brook, from which he received the Distinguished Alumni Award in 2011. He completed his anesthesiology residency at Yale University and was on the faculty at Yale and Johns Hopkins University prior to returning to the University of Pennsylvania. His research focuses on perioperative cardiovascular risk assessment and reduction and measurement of quality of care, and has received numerous federal, industry, and foundation grants related to these subjects. Dr. Fleisher is also the treasurer of the NQF Board of Directors. Some quick logistics before we get started. We hope you'll take an active role in the question and answer portion of the program. However, please help us stay on topic and refrain from questions or comments that aren't related to the information being shared today. We have muted all the phone lines to ensure that unexpected noise does not interfere with the program. We'll be taking questions through the web interface and through the phone lines. If you're on the web, we are displaying instructions there for how you can ask a question. If you are only on the phone and unable to see the instructions, I will prompt the audience when it's time for phone questions. At that time, you can hit *7 on your phone to unmute your line. When you've asked your question, please mute your line again by hitting *6. With that, I'd like to turn it over to National Quality Forum CEO, Dr. Shantanu Agrawal, to kick off the program. Shantanu, you can hit *7 on your phone to unmute your line.
Great. Thanks, Jonathan. Can you hear me?
Yes, I can.
Okay, awesome. Well, I just want to quickly thank everybody for joining us on this webinar again. It is now one in a series, and we hope to keep going as long as these webinars are attended and thought of as useful. So thank you to everyone that has dialed in during this very challenging period and to spend some time with us. Obviously, I want to thank Lee very much for also spending some time with us. I know he is very much in active preparation for the expected volume and caseload that UPenn expects to get. And he and I have discussed at length the preparation for various critical care needs that he is leading and involved in. I think this session will be extremely useful and I hope very practical for other members and stakeholders of NQF as they think about their own preparations and engage in them. So with that, again, thank you, Lee, and thank you for your service on the NQF board, and I will turn it back over to Jonathan.
Great, thank you, Shantanu. You can hit *6 to remute your phone. Dr. Fleisher, I'm going to turn it over to you. You can hit *7 on your phone, and we'll see if we can all hear you.
Yes, Jonathan, can you hear me?
I can. Go ahead.
Great, thank you. And the next slide. And it's a true privilege to participate here and talk about how we're thinking, both as a member of PennMedicine, which is a member of NQF, and the American Society of Anesthesiologists, another member of NQF. And just a little background to give you how we think as a system, that we are 6 hospitals in the Philadelphia region. We stretch from Princeton in the north to Lancaster General in the west, with Chester County in between, and 3 downtown hospitals. The Hospital of the University of Pennsylvania, which is our academic medical center, Penn Presbyterian Medical Center, which is our second academic medical center, and Pennsylvania Hospital, which is the hospital founded by Ben Franklin in downtown Philly. And we really started seeing the surge not unexpectedly, at Princeton Health, in that as it is really between New York and Philadelphia, that was the hospital that saw it first. We're now beginning to see it in our downtown hospitals. We have over 200 individuals. I have in the room here Jack Gucci, and I'll talk about that in a minute. And you can see the extent of our enterprise. And on behalf of our Dean and CEO, thank you for allowing us to give you our thoughts. So in the next slide, one of the things that we're fortunate enough, and although Princeton's one of our newer hospitals to join the system, we think a lot about systems. And I have in the room Jack Gucci, who is an anesthesiologist in the department, but we had set up a critical care collaborative that went throughout all 6 hospitals, and recently he was elevated to be associate CMO for the critical care section of the hospital. So that allowed us to quickly think through the issue of pulmonary critical care, anesthesiology critical care, neurocritical care, and surgical critical care, and really integrate that in our thinking about how to address this problem. Also having things like perioperative care and working closely with the emergency department, which also has several intensivists, we can look at how large a footprint can we create to maximize the amount of critical care and maximize the amount of ventilated patients, since I think we're all aware that the ability to ventilate patients is critical. And the data that's coming out of China and some data coming out of Italy from our colleagues in Bergamo really is suggesting that the length of time is in the 14 to 16 days. Some, of course, much shorter, but that this really is a Herculean task as the patients, as we continue to see the surge, will continue to be on ventilators in our units as we try to expand our capacity. Here's just some of the other key work groups that have been stood up, which is not the focus of today's discussion. Next slide. So as we thought about it, and we started about 3 weeks ago, nearly the very beginning of March, as we were hearing about Washington State, and I need to thank my colleagues in anesthesia who have given us these insights. We felt that PPE was critical and that simulation, both of PPE and airway issues, was one of the first things we stood up, and we'll talk about airway teams shortly, because it really takes 15 to 20 minutes to don and then another amount of time to doff the PPE for these emergent and high-risk situations. In fact, the idea of ventilating a patient with a mask and bag can spread the virus, and if you're not in a negative pressure room, that can increase the problems. The other thing, as we continued to do these simulations, it became clear to us that communication, if you're wearing the PAPR device, in which you have the positive airway pressure, that you can't hear and you can't communicate well. And that gave us ideas to start talking about whiteboards, and we are very fortunate to have a large number of cameras via a tele-ICU system and using that for communication. The other key thing, and I'll talk about in a moment, is really communication out to our staff. That while we have an incredibly large number of intensivists between the 4 divisions in the health system, they were really concentrated downtown at our academic centers. Some of our community hospitals had fewer intensivists, and how to ensure that we actually are able on a daily basis to get it to sort of a central group who can make decisions can allocate resources, and also given the concern healthcare providers have for their own safety, and we hear that almost daily on the news, how can we assure them that we are protecting them? Because in order to protect the population, we need to protect the providers. The last thing that's really become very important, and the resources that will be available once this crisis abates, is the educational resources. So as I talk about the number of individuals we need to train who don't have extensive experience in the critical care arena, I'll talk shortly about those who are critical care training with minimal additional education, as well as extensive education. We had to stand up a number of those resources, and I'll go over that in a moment. And we wanted to share, since it's out on the internet, this link. Feel free to use resources. These were created by Tim Galton in the department, as well as others, to help you think about and educate your frontline staff. The fortunate thing about COVID-19 is it is the management of ARDS. It's not the most complex management, so that many people can be taught how to do it. There are, as we're learning, a lot of cardiovascular issues that may occur. So those are some of the things that we're adding to the mix. Next slide. I just wanted to highlight something that a colleague of ours at the Wharton School wrote, and she sent me a couple nights ago, Sigal Barsed. Sigal is an expert in emotional intelligence. She wrote this blog that's out there on the web, The Contagion We Can Control. And really I wanted to highlight one statement, which is stemming negative emotional contagion and making positive emotions more infectious will make us feel more prepared and in control during this frightening period. I urge many of you, I sent it to all of my staff. It's been sent to many of the other faculty, as well as to our families who are home and worried about us, about what we need to actually help us deal with potentially being emotionally hijacked during this time. Next slide. One of the first things we knew would be a problem is if we're getting one patient per hour, and that's what we're seeing now in our downtown hospital overnight, and it may be increasing, is the ability to intubate these patients. As I discussed, the donning and doffing of PPE, it can take quite a bit of time. Traditionally, anesthesiologists, when called, come out of the operating room. They may be doing other things, other cases. In addition, the issue may be that the emergency department may be overwhelmed in taking care of these patients and could use help. Usually they do, frequently, they do their own intubations. And lastly, that in the critical care units. So approximately a week ago, we stood up a 24-hour team. It's actually two 12-hour teams. We used an anesthesiologist, a nurse anesthetist, and either a second nurse anesthetist or a resident. Here is a card, and we actually believe it's critical that you have a buddy system. It's very easy during these critical time periods to actually want to run in the room and save the patient. But if that's the case, you could end up being quarantined or get infected. And we remind people to actually almost have a checkbox or checklist in this equipment, and buddies are critical. Next. The Society of Critical Care Medicine has been promulgating this idea and this strategy, and we're taking on and adopting this strategy, that there are only so many trained or experienced critical care physicians, And I really need to give a shout out to our CMS colleagues who now allow us to use telemedicine to also build critical care codes and sort of allow us to think through utilizing either in the room or through telemetry or cameras, experienced critical care physicians. And really, you could have frontline nurses, non-critical care ICU APPs at sort of the lowest ring. The next level could be ICU nurses. The next level up could be respiratory therapists, CRNAs, the physicians who are not critical care. Finally, the non-ICU physicians who are easy to actually gain that experience, for example, cardiac and critical and liver transplant anesthesiologists. There are many anesthesiologists who essentially do critical care, but in the OR. There are cardiologists who can do some of this work, and we are pairing them with APPs from the ICU. So if you go to the next slide, in thinking about Manpower, we really have who are our critical care trained individual in whom we can actually remove from their other activities and really make sure that they're able to do this work. In fact, we frequently have thought about 4 days of daytime, 3 to 4 days of nighttime, because working in these COVID positive units can be quite taxing. They are frequently paired with critical care capable with minimal training, and we have already begun to relieve many of those providers and put them into units that are not COVID positive to get them ready and experienced. So before you have your surge, think about not only educational material, which I showed earlier and available on the web, but actually embedding them with the providers for additional training. We think there are those with more extensive training, and if we have time, we will train them up. But really, there are two groups. Certainly, we want frontline providers to be prepared, and then we're thinking a lot about teams. One such team I've already discussed, the airway team. We're beginning to stand up today in Philadelphia. As I said, we have 200 across the system. We're close to 60 at the hospital of the University of Pennsylvania. That as our ICUs fill up, the ability of an intensivist or an intensivist team to also insert central lines, arterial lines, we've got to worry about nutrition, has led us to work with our surgical colleagues, our medical colleagues, our anesthesia colleagues, to stand up a second team 24/7, and that will hopefully stand up in the next 48 hours. Many people believe, depending on the setting, that proning can be incredibly beneficial, and we're starting to think in a true crisis situation in which we're surging into operating rooms, do you have a team dedicated with nursing, with an anesthesia provider at the head of the bed, a CRNA or an anesthesiologist or an anesthesia resident, and other people to help with the proning task, since most people recommend twice a day. We actually don't think we have a lot of respiratory therapists, but if we expect to have 500-600 vents in a single setting, there are not enough respiratory therapists. So we're starting to train our CRNAs and our anesthesia residents in basic respiratory care. And I've talked about telecritical care. Next slide. That real estate is a very important issue right now. The critical care units, people initially said, well, they'll be in the medical ICUs. Those were quickly filled, particularly if we initially said it would be negative pressure rooms to avoid contamination. So a question is, can you change the entire unit to negative pressure, or can you seal that unit so it doesn't contaminate other units? And I'll talk about that in a moment. And then in the SICUs, in the neurointensive care units, in the trauma ICUs, and in the heart and vascular. And you have to think clearly, since we still have non-COVID patients, how do we ensure we can provide critical care such that the cross-contamination, which was the biggest issue in Italy, how do we think about that? What are the other critical care capable units? We have an observation unit in our emergency department. Convert that to critical care, but then you have to think about staffing. We all are thinking about ORs and PACUs, and the advantage being we can use anesthesia machines. But the HVAC systems are non-trivial. How is your OR connected such that are you going to contaminate the entire OR if they're on one system, or are they really isolated? And with additionally, my colleague who's also in the room besides Jack Gucci, who's the Associate CMO for Critical Care, Maurizio Serrata, talked about the use of oxygen helmets in a recent Wall Street Journal article. Next slide. And I want to end before the question and answer is the things that we're thinking about quite a bit. The sedation issues. If you're thinking about 2 weeks of ventilation, 16 days, potential shortages of opioids, benzodiazepines, ketamine. I've been working with the American Hospital Association to help them with the issue of, given DE regulations, do they understand the markedly increased needs that we may need for opiates? And the tolerance is high in these patients, and people are using ketamine and other agents. There are also, with the anesthesia machines, could we use the anesthetic agents as sedation as long as we have proper screening? Scavenging, excuse me. We have to think about extubation, an important issue, and these patients could still be shedding virus. And lastly, and not a topic here, but something we think a lot about, is in the worst part of the surge, how do we think about palliative care and medical decision-making and issues of appropriate utilization of resources? So, Jonathan, thank you for the opportunity, and Shantanu, and I'll end there and be happy myself to take questions or refer them to my colleagues in the room.
Great, thank you, Lee. So the first question that we have is from Lorna Lynn. Lorna, do you want to unmute your line by hitting *7 and ask your question? All right, we're not hearing Lorna, so I'll just ask the question for her. She asked, do you have the PPE that your teams need?
That's a difficult question. The answer is no one in our system is asked to go into a COVID positive room without proper PPE. And we've seen things from New York, again, that says people shouldn't go into COVID positive rooms until they have the proper PPE, even if that delays resuscitation. What we have done in the last, I think it's 48 hours, is given everyone in the health system a mask. That's just a regular mask. We've gotten lots of donations from nail salons and other places, so adopting Atul Gawande's issue. The critical thing is for the non-COVID patients who have airway issues, the asymptomatic patients. For anesthesiologists, we are reusing masks for the high-risk intubation because it could aerosolize somebody who has a low virus titer and not quite sick. And those we are reusing. But we certainly have enough PPE for anyone who has to care for a COVID-positive patient at this time.
Okay, our next question is from Nancy Foster. Nancy, do you want to hit *7 to unmute your phone and then ask your question?
Hi, can you hear me?
Yes.
Yes.
Hi.
Hey, Lee, it's good to hear you, and thank you very much for this presentation. I want to take you back to your last bullet point and ask you to talk a little bit about the process you're using or you've thought about using in order to support clinicians in the event we get to that point where really tough decisions have to be made about allocation of resources. How would you go about that at Penn?
Thank you, Nancy. We're very fortunate that we have a Department of Medical Ethics, and we actually also have a PARE Center, which is a palliative care center headed by Scott Halpern. And they've been developing documents to help think through these issues. I think there's really two issues. If someone codes and you need to resuscitate them, how long do you do it? And we're still working on what's in a proper amount of time. And for those more difficult questions, and Jack might be able to help us, we're standing up not yet, but if it's ever needed, we're identifying intensivists and others who could be separate from the primary caregivers and able to assist the primary caregivers in having the discussions with the family and speaking. Jack, do you want to say anything further?
Yeah, in anticipation of having, potential limitations on resources, this group has developed a set of recommendations and basically pathways guiding a triage center using, basically a complicated severity of illness score system that would include the SOFA score system, which is modified to set levels in a hospital so that you could factor in multiple factors that would, create a score to assist the triage officer in the case that you have to make decisions based on who would get care and who would not.
So thank you for asking that. We're not yet ready to share it because we're very far from needing it, but we think it's critical to identify the physicians who think they can do it and do it separate from those who are in the field. One of the things we've been thinking about is our intensivists after 4 days in a unit may need some rest. This isn't rest, but it's at least not direct patient care. I hope I gave some insight into how we're thinking about it.
You did. Thank you so very much, and thank you for this presentation. Very helpful.
All right, our next question is from Jeffrey Grossman. Jeffrey, do you want to hit *7 on your phone to unmute and ask your question? Okay, we're not hearing Jeffrey, so I'll ask the question on his behalf. How much standardization of treatment protocols do you have across your system?
I'll refer to Jack because that's really what he's been doing, and importantly, we've been socializing, particularly with the other. We have both the academic and private practice anesthesia, so on that side, we've been socializing. And Jack on the critical care.
Yeah, so this critical care committee has representatives across the health system from every ICU. So we've been doing this for 5 years, standardizing insulin management, ventilator management, sedation management, and the list goes on. So most recently, we've been rapidly, cycling COVID-related protocols through this, including ICU-specific care, extubation guidelines, intubation guidelines, pharmacologic treatment guidelines. The infectious disease folks have been able, through this forum, to also facilitate treatment guidelines. The list keeps getting larger and larger.
And we'll talk to our leadership to see how much we can share and put on the appropriate websites as we get more prepared. But it really has made a difference. Jack also stood up a education subcommittee headed by Emily Gordon, an anesthesiologist in the department, to really develop a lot of this work to disseminate it out to the entire group. She's working closely with the Department of Medicine and the medical school, and much of that material is already out on the web.
Okay, moving on to our next question. It's from Asaba Nwafor. Asaba, do you want to hit *7 on your phone to ask your question?
Yes, sure. Thank you for the presentation. Can you hear me?
Yes.
Yes.
Okay, awesome. My question is about mass testing of everybody that presents into the emergency room, because a lot of people are asymptomatic. So when do you plan to roll out mass testing for everyone that comes to the hospital so that they don't unknowingly infect, especially healthcare workers, since there is going to be a capacity issue?
And so we do not have the capacity right now to do mass testing. I know that we're thinking of anyone who comes to the operating room does. And Children's Hospital of Philadelphia had stood up their own PCR-based test before us. So it is, I'd have to defer to the thinking unless someone in the room.
Well, I think the problem is that unless the patient reaches a certain viral load threshold, you're gonna get a negative test. So we've had patients who looked like they were, had, a fever, infiltrates, and had negative tests. Now, the question is whether, the test is not 100% sensitive, so you can get false negatives and have a false reassurance that your patient is negative. But there is also the patient who comes in and then 2 days later will develop a viral load high enough that they would be positive, and you've let them sneak in but be reassured that you've got a negative test.
So it actually gets to the interesting question of when we have the capacity, and we hope soon, to do rapid testing in all patients, would we say that somebody is really negative if there's true community spread? And almost the more we can treat everyone for critical portions of the case. For example, as an anesthesiologist, the intubations and extubations in all patients now are done with either the rest of the team outside the room or at least 6 feet away. We wait for a couple air cycling because of the potential to aerosolize a low viral load, the patient who would be a negative, a false negative, and proceed from there. So I don't think we know the answer yet of being reassured, but we hope, but it's something that we're thinking through.
Okay, our next question is from Don Casey. Don, do you want to hit *7 on your phone and ask your question? Okay, we're not hearing Don, so I'm going to ask this question for him. The question is, what role are medical and nursing students playing in these scenarios?
So that's an interesting question in that our school felt it was inappropriate to bring these students into the clinical situation. Others may choose differently. Ironically, if the fourth-year students who matched to Penn are going to start early, which means earlier in June, but there are none. Now, in the clinical situation, we actually have two things that they've stood up. One by the students, which is, can we help babysit for all the providers coming to work, which is a wonderful thing. But the second thing is, in our tele-ICU, we've actually created a rotation for them, and they are there as scribes, as learners, as incredibly valuable assistants for some of the remote work that we're doing in the critical care area. Again, I don't know if all schools have taken this approach, but they feel that it would not be appropriate.
And research also.
And they're also helping in the research labs because there's lots of research being done, as Dr. Sereda just reminded me. I think the same in nursing.
Okay, great. The next question is from David Longnecker. David, do you want to hit *7 on your phone and ask your question?
Hi, David.
Hello, Lee. Can you hear me?
Yes.
How do you, well, let me start by saying that Penn has a distinguished medical ethics department. How do you plan on triaging who gets full critical care and who doesn't as this next couple of weeks with the anticipated surge emerges?
David, Nancy had asked a similar question. Is there something more specific than Nancy's question? Because we do have pathways, we just haven't, we're not yet ready to say specifically when they come in. I don't think we're saying when.
No, right now we haven't. In anticipation of that, the only thing we've done is limit surgeries to urgent, to increase capacity is to limit surgeries for urgent and emergent procedures, cancer, cardiac surgery with symptoms, that sort of thing. But we haven't been, at this point, triaging care based on any factor for patients presenting with COVID symptoms.
But David, given your role and CTAC's important role, and what hopefully people can disseminate, the discussion was, okay, you're now in the hospital and we're trying to make decisions on your personal desires around palliative care, end of life. And we think that's too late. In fact, we think the discussions hopefully have begun at home during this situation, given we're really talking that if you need intubation, it's prolonged in most cases, and perhaps even in the emergency department. So through CTAC, hopefully they can think more and more, and others on the call can think about starting those discussions the minute you meet the patient so that it really can track them and again, utilizing the right resources.
I spent the morning with several different organizations addressing exactly that issue of starting early.
Thank you for that.
Great. Thank you for what you're doing.
Okay, so we'll open it up to phone questions now. We have about 130 people on the phone, and almost all of you are on the web too. So if you get the chance to post your question in the chat window or raise your hand on the web, it makes it a little easier. But we'll open it up to the phone lines now. If you want to ask a question, please hit *7 on your phone and start to ask your question. I see a question from Matthew Knott. Matthew, do you want to go ahead and ask your question? Remember to hit *7 on your phone.
Yep. How are you? Everybody hear me?
Yep.
Okay. A quick question is just if, we're hearing a lot of talk throughout the country, but one of the things that we're planning on through our Emergency Operations Center is the potential for setting up a large-scale healthcare site in a convention center or similar facility. Is there any specific guidance or a checklist that would help us provide some framework to do that?
That is outside of my primary area of interest. The one thing is we've been looking at sites. Some interesting questions that I've heard arise, and again, I'm not the expert, is do we have Wi-Fi access? Because if you don't, the ability to actually log on to the systems and get access is very difficult. The other non-trivial issue, and Maurizio, that I've heard people speak about is suction and issues for the pulmonary. So as we think about where we can use sites, I think the equipment becomes an issue.
think about a lot of different things. For example, do you have compressed air supplies, which will limit the ability to use ventilators and other types of devices. Suction is one of them. But think very carefully about everything.
Yeah. Sorry we can't be more helpful.
No, that was helpful. Just a little bit different perspective, so I do appreciate that.
Okay, our next question is from Michael Alexander. Do you want to go ahead, Michael? Okay, we're not hearing Michael, so I'll pose the question for him. Michael asked if there's going to be antibody testing for immunity to COVID-19 soon, and if so, how do you think that'll impact the treatment of patients once it is available?
So ironically, we've been discussing that. Again, I'm going to be channeling some of the experts here at Penn, is that we do have people doing antibody testing. We just don't know if they have antibodies, whether that truly confers immunity. Maurizio, do you have any other?
No, I don't. We're studying it.
We're studying it, and we're sending people. We're actually getting IRB approvals by some of our basic scientists and immunologists here. So once we know whether or not antibody testing does confer immunity, then it would be great to deploy those people in COVID units without the PPE.
And then the other thing is the convalescent plasma question of, is that useful in somebody who's had known exposure, survived, and has antibodies, whether you could use their plasma effectively to treat somebody with known COVID, with severe known COVID.
I mean, there are lots of studies ongoing. Places like us are standing up these studies, and the problem is that we don't have answers yet. So people are talking about things that are not yet clearly efficacious. And the worst thing I think would be to say, oh, you have antibodies, re-expose somebody and reinfect somebody.
Yeah, so many unknowns and things yet to be discovered about this. Our next question is going to be from Christine Imold. Christine, do you want to ask your question?
Good afternoon, and thank you. My question is relating to the OB population. So have you encountered any OB patients in your critical areas with either confirmed or suspected COVID-19? And if so, can you share what plan of care you are seeing being implemented with these patients?
So the answer is absolutely. In fact, what we have done, and I didn't talk about that, is we have either one or two operating rooms that are COVID positive or PUI designated in the OR, and I think about 48 hours ago we stood up a similar COVID positive OB operating room for emergency cesarean sections. So many of you may have seen the article in the New England Journal Catalyst from Bergamo, Italy, that was highlighted in the New York Times recently. Dr. Sereda comes from Milan and was one of the authors of that paper. And I don't know whether you're going to talk about Milan, Bergamo, or here.
For here, I'm aware of one patient who is actually in our ICU, had a C-section done in a dedicated room. I don't know about the state of the baby right now. The mother is on a ventilator. The C-section was done early to allow the resuscitation of the mother, of course. For Bergamo, I can tell you the story I got from my colleagues over there is that the inability, the lack of planning, that's actually an important aspect. The lack of planning on how to deal with what to do the OB service led to the contamination of the whole OB floor, which determines several different things. So mothers come in, get infected, the staff gets infected, the children probably get infected. We don't know anything about what's going to happen to these children in the future. So one thing that is important is you have to think about the way early or how you're going to protect your OB service from the virus, potentially using a separate facility or thinking very careful about pathways separating COVID positive from COVID negative patients. A dedicated unit or a dedicated building is probably the best choice.
Okay, thanks for that question, Christine. Our next question is one that is part of a category of questions that we've gotten a lot recently, which is related to family presence. And Kelly, do you want to go ahead and ask your question?
Yes. Can you hear me?
Yes.
Okay, great. This is Kelly Goodson from Vizient. Thank you for your presentation. I'm just curious how you're handling family presence at this time, and if you're limiting and restricting family presence, how are you communicating the the care plan and the updates with the family?
Yeah, we have actually totally restricted family presence. And Jack, if you can highlight how our ICUs are communicating with families.
Yeah, there is the ability to FaceTime with families. We've had social workers, et cetera, be able to bring phones in to FaceTime, but it has dramatically affected our families' ability to meet with the patients, and you can imagine they're having anxiety about this. We do allow, in some circumstances, when a patient is imminently going to die, for them to briefly visit the hospital in our policy, but this has really been a problem for everybody, not just the COVID patients.
In fact, the issue of having families for deliveries has really become a national problem.
Yes, it really has, especially the state of New York. They were the first to come out really limiting that restriction, and then Governor Cuomo put in an executive order reversing that restriction. So, it's interesting how the restriction of family presence really does affect the staff as well and the ability to care for our patients.
And, one question I would ask, and I was there when at Johns Hopkins when we were thinking about smallpox and had concerns. And one of the things we thought about is, do you move clean OB to all these ambulatory surgery centers? And it's just, we have not done that, but we have lots of thought processes, and it's just something to think about.
Thank you very much.
Thank you, Kelly. Do we have any questions from the phone? I see that Susan Frampton has raised her hand. Susan, do you want to unmute your phone and ask your question? Okay, we're not hearing Susan, so we'll come back to her.
This is Kelly.
Can
you still hear me? Can I say something since Susan's trying to get on the line? I do want to applaud Plaintree. They've put out some additional guidance for hospitals and healthcare organizations to consider when we're talking about family presence in the time of a pandemic. So if you haven't seen that, you can go to Plaintree's website. It's really good additional guidance.
Thank you. That's something the stresses are unbelievable for our patients and their families. So it's helpful to know anything we can do to help them.
Okay, Susan, I tried to unmute your line on my end, so if you want to try to speak again, we'll see if we can hear you. All right, we'll try to come back to you. The next person that has their hand raised is Nancy Jester. Nancy, do you want to hit *7 and ask your question? Okay, looks like we'll have
Hi,
to come
can
back
you
to
hear me?
Nancy. Oh, yes, we can hear you now.
Sorry, I had my phone on mute. I *7, but didn't unmute. I was just wondering if Penn was considering furloughs of physicians that are not in a critical care position at this time.
Not to my knowledge. We actually have recognize that at least at the university, the hospital of the University of Pennsylvania and Penn Presbyterian, the physicians are all faculty and are all salaried, at least our base. And what we have done, the critical care departments are essentially being allowed to redeploy internally, but we've stood up a lot of telemedicine, and essentially all staff, there's a central grouping, and we're saying, what can you do? And hospitalists can turn into frontline providers in the emergency room, et cetera. So the real goal is to redeploy all our resources because they are a fixed cost in most cases. I will tell you that just for transparency, there are some emeritus faculty who work on a intermittent basis who have just decided to retire after talking with me because we've used CDC guidelines for high risk, so over 65 or those with the chronic conditions, and said those providers, our goal, if they have a high risk of mortality, should not be in locations that are immediately that they could be exposed to the virus as part of their care. We've also had residents as well as faculty who have taken FMLA because we've asked their physicians, do they fit in that category? For example, individuals on chemotherapy, individuals who have autoimmune diseases. So otherwise we say that this is a time of crisis and we need all available physicians to act as best as they can.
Okay, thank you.
All right, so we're going to go back to Susan Frampton now. Susan?
Yes, can you hear me?
Yes.
Okay, great. So I did just want to talk to Kelly's point earlier about family presence, and I wanted to just bring to people's attention some of the unintended consequences that we've become aware of by essentially restricting visitation as strictly as we're seeing this happening. For instance, our headquarters is at a hospital in Connecticut. This hospital is seeing women, laboring women from New York State, driving over the state line to labor and deliver at a hospital that still allows their birth partner to be with them. There are obvious risks to the woman in a case like that, but this is what people are being driven to. We know of other cases where family members have removed their elderly relatives from long-term care centers that will not allow any family presence. We've heard of cases of parents very reluctant to bring their ill children into the local emergency rooms when they know that there is a policy now in place of separating them. So I would just caution us to be very, very aware of the unintended consequences. And when I go back and I look at the CDC's guidelines, I do not see anything that is recommending that we eliminate family presence in these kinds of situations, in addition to the obvious one that was mentioned, which is a terminally ill patient who's about to die.
Thank you. We are also seeing women driving to Philadelphia to still deliver down here. We're seeing a lot from New Jersey coming over to here. And what I have to really applaud both CHOP and the Hospital of the University of Pennsylvania is the ability to really do telemedicine and the work of CMS and our insurers to allow it. Hopefully many of those healthier individuals can stay at home and get their care they need through some sort of telemedicine.
All right, we've got time for one last question, and that's going to be from Libby Hoy. Libby, do you want to ask your question? Try again, Libby. All right, I will pose the question for her. Libby asks, are patient family advisors involved in the family restriction policies during development and implementation of those policies?
I honestly don't know. This was really a policy that I think was to limit the amount of exposures of asymptomatic patients, of asymptomatic individuals to both our healthcare workers, since not everyone can wear a PPE all the time, and to our patients. They are involved, I believe, in some of the triage work that's being done by Dr. Halper and our medical ethics. But Maurizio, do you have?
No, the issue was in Italy was also family members coming here getting infected and taking the infection home. So the hospital have become hotbeds of infection. It's a harsh policy. The no visitation policy is very harsh, but at the same time it protects the community. Because what's been happening is that the hospital has become hotbeds of infection, so they spread infection into the surrounding area. So that's something to keep in mind.
Difficult discussions that when we this crisis is over, hopefully places like NQF can start to think about how do we look at population-based metrics to really say what's best for the population when this hopefully will not happen again, but we need to be better prepared about thinking about it for the future.
Well, Lee, I want to thank you and your colleagues there for taking us inside the preparations that you all are doing, and also being willing to answer people's questions just generally about this. There's so many unanswered questions right now, things that we're all trying to figure out, and having experts like you on the phone to help us think through and talk through these things is great. Do you have anything you want to say in closing before we wrap up?
No, and I want to thank the questions. They make us think. These are things that we have to consider. I listed my email. It may go down overnight, but it'll be back up tomorrow. But I'd be happy to answer questions or hear your thoughts. And thank you for participating.
All right, just so in closing, I'll just ask everyone to be on the lookout for a brief survey about today's program. If you could take just 60 seconds to give us your feedback, we'd appreciate it. I also want to encourage everyone to tap into our amazing community of healthcare quality leaders as we navigate these challenges together. We have an active conversation underway on our online community, Member Connect, and the recording and the slides from today's programs will be posted there shortly. So be on the lookout for that. So this concludes our program. Thank you again, Lee and colleagues. And on behalf of everyone at NQF, we wish you all continued good health amidst this pandemic.